First,
Thank you so much. I'm not sure how to move the slides. Can I request? Okay. Um, can I request Lexi to move the slides for
Yep,
me?
it should have just popped up for you. Did you see it?
Yeah, it did, but I'm using a very small screen. So if you can just do it for
Okay.
me, I'll be
Yep.
happy. I'll just tell you when to move the slides. Sorry about that.
No worries.
Right, I'll just start with introducing myself. Thank you very much. Hi, everyone. I'm Shital Daftari. I'm the founder and CEO at S&T Biotech, and I am Harvard OPM 62. Thank you so much for this opportunity to share the work that we are doing to improve preventive screenings and health outcomes across the country. I started S&T Biotech, this mission during the pandemic when I witnessed the deep disparities that existed in underserved communities. What started as an emergency response to crisis has grown into a mission-based, mission-driven company, and we help health plans close care gaps, improve screening outcomes, and ultimately save lives. And can we move to the next slide, please? Yeah, so the problem we are solving is simple, but it's really massive. Every year, millions of people miss essential preventive screenings that such as colorectal cancer, diabetes, cervical cancer, and kidney health test screenings. And these are the tests that are very inexpensive and life-saving and required by health plans. But the reality is that health plans consistently struggle to engage hard to reach populations, usually the Medicaid members, the rural populations, and the people who lack access to care, and a lot of social determinants, and also have a lot of social determinants of health present. So when the screenings don't get completed, members they face late diagnosis and face health disparities widen, and health plans lose millions of dollars in bonuses for their star ratings and HEDIS performance. It's both a health equity challenge as well as a financial challenge. And this is where we come in. And we'll move to the next slide, please. Yeah, so at S&T Biotech, we have designed a fully integrated solution for at-home screenings. What makes us different is that we have the whole entire journey from start to finish. What we do is we build and ship at-home test kits that can be completed in the homes for chronic condition. We ship these test kits to the homes of the members, to health fairs, and to community partners. We execute multilingual omni-channel outreach, such as calling, texting, and emailing the members and sending them reminders specifically for them to return these and to nudge them to return these test kits. We've also developed an AI-powered platform which gives health plans real-time dashboards across the kit activity, outreach touchpoints, and compliance rates, as well as the results. So, and because we also own and operate a CLIA and COLA accredited lab, we process the test kits in-house with fast turnaround time and high quality. So everything is under one roof, which allows us to deliver high completion rates and more equitable access. Can we please move to the next screen, please? Now we're talking about the opportunity here. Opportunity is pretty massive. Preventive screenings market is a $40 billion industry in the US. And these is almost over 125 million people who are Medicare and Medicaid members who need these preventive screenings every year. The at-home diagnostics market is growing at a 10% compounded annual growth rate. And then there's also the push towards value-based care models, which requires all these screenings to be completed. And last but not the least, HPV screening remains a very big gap in screening because there has not yet been an FDA approved at home test yet. And so there's over 50 million women waiting for their HPV test screenings every year. We go to the next screen, please. Yeah, so currently we partner with a large number of health plans, federally qualified health centers, as well as employer groups, and help them to reach to their members and help them complete those screenings, such as Centene, Blue Cross, Altace Health Systems, Molina Healthcare, Meridian Health of Illinois, Hennepin Health, and many others. Let's go to the next slide, please. Sorry, that's not sorry, there's one more slide. Can we go to the next slide, please? Yeah, sorry.
It's the only one that copied over.
Oh, that's it. Oh, there's two more slides. Anyway, so I'll just share what is next. So there's two more slides. So what's next for us is at home HPV screening. So our next major milestone is we are going to be offering today HPV screening for cervical cancer, HPV testing for cervical cancer screening nationwide in Q1 of 2026. Today, HPV is only approved for self-collect in
One more minute.
Yes, FDA approved for in a self-collect setting, in a clinical setting, but in the next Q1 of next year, we are expecting at-home approval for the HPV screening, so that we are going to be able to send out HPV test kits to the homes of many, many underserved women and helping them complete their screening for cervical cancer. This solution will include everything from self-collection, multilingual outreach, culturally relevant outreach, logistics, lab processing, and live dashboard. This way, we will be able to save lives of millions of women nationwide. Then we had a slide about our team. I'll just skip that really quick. But really, we are not asking today to raise any capital. I'm just looking for collaboration. We are looking for collaboration with health plans, federally qualified health centers, population health teams, and innovative leaders and organizations that want to expand and access and improve compliance rates. So if you're connected with any health plans, provider groups, or focused on STARS, HEDIS measures, or health equity initiatives, I would love to chat with you. Together, we can close gaps, improve completion rates, and save lives through early detection. Thank you so much, and I'll be happy to take any questions.
Well done. You did it in the 5 minutes. Appreciate it.
Thank you.
Go ahead, Lillian.
Yeah, thanks. I mean, this is a space I've done a lot of work in, and I'd love to chat with you later. You talked about HPV. What other tests? I mean, chronic could be diabetes, could be hypertension, could be, I mean, women don't get their mammograms either, but is that something you're looking to address at home,
Yes,
right?
Yes, we are doing all gaps, and we're not doing mammograms yet, but we are doing all the gaps in care, which are like the measures, the ones that are value-based care measures, such as colon cancer screening, A1C, that's diabetic screening, HPV screening, and kidney health. That would include the EGFR and the UACR. We can also do like cholesterol and lipid panels and all these preventive screenings that are life-saving. Thank you.
Sure, happy to chat. Yeah.
I'll be happy to connect offline.
Yeah, I'll be happy to connect too. I have a quick question about, and I love all the preventive opportunities. I think it's great. You're onto something there, really big. My question though is it really helpful strategically to bring all potential preventable interventions versus segmenting them and offering them separately? Because when you're kind of mixing and matching a little bit of everything, sometimes recommendations may change or people may get like, well, but you don't know if this or that will work. Would it be helpful? And have you considered that? And, and if you have any thoughts about that.
Yeah, 100%. We can bring in a lot of preventive screenings and put them together and offer them to people. But right now, we are focused on underserved populations and people who lack access to these screenings. And then who is going to pay for them, right? So right now, the health plans and the federally and the value-based care systems, they have specific measures. So we focus on those measures because they are inclined, because it's linked to their quality metrics, and in turn they get higher, they get bonuses based on completion of these tests. So that's why we focus on these chronic gaps in care. These are called gaps in care, and we focus on these because we can offer, but with underserved population, and as it is, they're not going to the clinics, so they're not going to order it themselves. So we have to go through a health plan or a federally qualified health center who wants to push these tests. That answers your question.
Barry?
Just quickly, I live in a state where we have some huge, very dense cities, Texas, and then we have a lot of rural areas, which I think my guess would be there is just as bad off as anything you can find in the cities as far as reminders to get tests done, because you're talking sometimes 50 miles to get to a doctor. Have you looked at that whole thing about trying to make sure you're helping the rural communities?
Absolutely. We are already doing that. We are working with a lot of health plans nationwide, and specifically the rural, the hard to access populations who lack access, the rural populations like Arkansas. We are partnering with a lot of payers and federally qualified health centers in Arkansas to help them with those rural populations. Cool. And that's why these are at-home kits. These kits are mailed to to the homes, and then, they can be self-administered, like, with a like finger prick and collecting stool, and that can be returned directly to our labs. And we do an outreach. We don't just send the test kits to them, but we follow up with them through text, phone calls, and emails. And so that we
Excellent.
actually
Okay.
return them.
Thank you. Yeah, that made it clear for me. Thanks.
Yeah, would happy to connect offline as well. Thank you.
Just one quick question. What's your biggest challenge in terms of these partnerships to add more partners?
Yeah, so we have been having a lot of interest from a lot of health plans, and we are already working with many of them. One of the biggest challenges is a long sales cycle. So working with payers is, it's really a lot of, they have a lot of different teams, and the contracting time is longer. So that's one of the challenges we've faced. But other than that, we've built the whole solution. We are up and running. We built the lab from scratch. So we have a CLIA and COLA accredited lab. We've got the test kits which are approved. We've got the messaging. We've got the software, the technology, and the dashboard, population health dashboard. So we are pretty ready for that.
Great. Thank you. I think we're ready for our next presenter. So it's Christina Breiter, I believe, of
Yes.
Toggle AI.
Yes. Hi,
Hi,
Christina.
Christina.
Now, how would I find the slide? I'm not sure that I'm able to see how I can access them. Click.
Did you just receive a notification to take
I
control?
did. I clicked,
Yeah.
but I don't see any slides yet.
So you're going to use the same screen. And if you just use your mouse on the share screen.
I apologize. I'm not
It's okay.
seeing
It's
it
okay.
either.
I can do it for you.
Would you mind? Thank you so
Not-
much. So hello, everyone. Thank you. A very hard act to follow. I will do my very best, but I am Christina Breiter, co-founder of Toggle AI, class of 1993. We have a novel form of AI, which we call CompCog, or computational cognitive AI. And as we bring this to the market, the first application is in mental health. Coming out of the pandemic, I think mental health has finally taken some more, become more aware. Everyone has become more aware. If you could potentially go to the next slide too, please. I'm sure everyone has seen the heartbreaking case of a young person committing suicide. It is just heartbreaking to think about that there are 20 vets every single day who commit suicide. Those are staggering numbers. As HBS also taught us, you go with what you know. My husband, who is the inventor, is trained as a psychiatrist. So we felt that the first application of this AI was towards an automated mental health assessment tool. So it's been 30 years in the making, and it is now ready it took us a long time, about 9 to 10 years, to take software from the lab and a framework from the lab and turn it into software that actually could be used in a commercial setting. We worked this summer with our congressional representative, Catherine Clark, here in Massachusetts, and we're able to get into the Appropriations Committee report a direction to use our technology in helping suicide prevention at the VA. So we're looking to, in spring of 2026, to service 120,000 vets. We're still determining which VA hospital we will go out of. But could you go to the next slide, please? So as many people here, AI is out there all over the place. Most AI systems are retrospective. They're collecting all kinds, as you think of ChatGPT, collecting all kinds of data from the past, and it's big data, doing an enormous amount of crunching to come up with predictions. What we have is a very simple task that we have people do. It's looking at 48 pictures, which you can do on a smartphone, and you rate them from -3 to +3, just how much you're interested in looking at the picture. The photos range from puppies to sports to some partying to scenery. And what's interesting and what we have discovered, or the AI behind it, the framework, is that what you're doing is you're moving through mild stimuli. And it's not how you rate the picture that's critical. Whether you say you like disaster pictures or something, what's important is the pattern of you moving through mild stimuli that gives us information about your judgment. And through the research, so then it goes into our CompCog AI, and this is our enterprise version, and then predictions. We've recently published a couple papers in some high-level journals, peer-reviewed journals, which shows that with 95% accuracy, we can determine using this simple process whether a person has a plan to kill themselves. As you broaden to depression or anxiety, the percentages go down to more like 80 something percent, but these are significantly higher. And it is a very simple assessment. Why it works is if you think about somebody swimming in a pond, they leave a wake.
Tina, you have 1 minute left.
Okay. Studying that wake, you can determine a lot about the individual. If you could go to the next slide, that's exactly what we're doing here, and that's how we make the predictions. The next slide just shows a lot of we have patented this. It's used number of, this is more the validation. If you go to the next slide, please. These are the various organizations that it has been funded out of the White House, through the Office of Naval Research. These are the various institutions, and we've published with a number of Nobel laureates. Next slide, please. Oh, this just shows us in comparison to various competitors that are out there. The next slide, we're clearly ahead of them with precision and funding. So where we are now, we are in a much earlier stage than the previous presenter. We're really coming out of the academic environment, moving into the commercial environment. We are closing up a small raise, $750,000, to get us to our first contract, really to get us to the VA contract that we're expecting in the spring. We're speaking with a number of corporations. We also have our product deployed with a couple of healthcare centers to look at how quickly we can help clinicians in their assessments and reduce the amount of time, and therefore get to actually helping individuals as opposed to spending the time trying to diagnose this. Again, this is not a diagnostic tool, it's an assessment tool at this stage. I think of it much like a blood pressure cuff for mental health. It gives you an idea. It helps to point the direction to the clinician to figure out where they can be most effective.
Christina, I think we'll go to Q&A now.
That sounds great. Perfect.
Questions?
I have a question and suggestions. I'm really within this space, so it's always so important for us to check for safety and things like that. We usually use a lot of PHQ-9, depression, stage, and SI. So even if you're creating your own survey or assessment, it would be fantastic to see how it pans out with other things that are already available. The other thing is, and of course, you may already have those connections with a VA, but also if you want to go through the Department of Defense and I actually worked years ago with the Defense Centers of Excellence. I think it may have changed the name, but having that connection can position you, and then they can pick and choose where they want to run your trial. So that would be a great opportunity to just do it, from the top down, and then figure out where you want it to do this. So this is always going to be super important. I love how you put everything together. And the other question was also about grants. Like, you could obviously also request additional grants to fund your studies. So hopefully that's helpful.
Thank you very much.
Yeah.
Christina, did I understand correctly that this is not a direct to consumer, but is you're going to work with providers and they would use this tool to help them? Did I understand that correctly?
That's where we are at the moment. Absolutely. We figured it was a better, safer way to approach all of this initially, but you could conceive of how one could go to direct to consumer. But again, we've been moving rather slowly and stealthily because I believe there are a number of ethical issues here. And so we want to move judiciously and carefully as we sort of introduce all of this to the commercial world.
Yeah.
Providers would be interested for sure, and the payer systems also, because there's a lot of case management done on that end as well, or in contact with providers. So there could be a lot of interest there. You just need to validate your assessments and make sure that they are comparable with other things that may be available already, so that people are going to be excited about it.
Thank you.
I have a question if we have time.
Yeah, go ahead.
I was just curious to hear about if you found in your research that the assessment that you use based on response to some pictures, how does that compare to other markers for mental health conditions like there's voice, text, body language, etc.? Did you find that this assessment is sort of better or leads to better outcomes than other markers?
To be honest, we haven't compared it to other markers. I do believe that the assessment, because what you're looking at is people's judgment, how they make decisions. And it's also in real time, unlike a lot of most other things. So we haven't compared it to other systems that are out there. We've been comparing it to what is being used right now. And the advantage of this system is, unlike surveys and all those other things, you can gain those very easily. You know if you want to raise your hand and ask for help. The most poignant situations are the people who really need it, are not the ones who are raising their hand and saying, yes, I need help. And that's what's particularly useful about this one is, again, it doesn't matter. You can't say, oh, if I say I like the toothy animals, that's going to mark me. It isn't that. It's how you're swimming through all of the stimuli. It's that pattern that is what is significant.
Thank you, Christina.
Thank you for the opportunity.
Very welcome. We're moving on to Elektra Health and Jannine Versi. Hi, Jannine.
Hi, everyone. Good afternoon. Thank you very much for having me. I'm Jannine Versi, co-founder and CEO of Elektra Health. And let me see if I can advance this slide up. I think I'm having the same issue that other folks were. Oh, Alexi, I'm clicking the arrow. Is that not the right?
So if you just use your keyboard to go right, will it go? Is that another option? No. Okay, we tested this earlier, I promise. I see your name on there too.
I believe you. Oh, I think. Okay. Anyway, so happy to join this group. I have come to the women's health space where I've been building Elektra for the better part of 6 years, having worked in healthcare, technology, and government for most of my career. So prior to Elektra was at a organization called City Block Health, which is digital health unicorn, value-based care, $6 billion business. I was number 10 on that team. But part of the reason I left City Block was, even though we had a really fantastic model for primary care and engaging individuals with complex medical and social needs, we were not thinking about delivering healthcare to different populations based on sex and gender. And that seemed like a huge missed opportunity, given the fact that we've seen a lot of innovation in the family building, fertility space, maternal health space. We need more, but the perimenopause to postmenopause milieu is really where we focused and saw, huge gaps. So I'm hoping that I can advance these slides. I'm not sure if they're okay. There we go. The model that we introduced at Elektra is specialty clinical care. So focusing on menopause specifically with clinicians who are trained in menopause medicine. They have come from primary care and OBGYN predominantly, and then basically subspecialized. And we work with health plans to make this access to the care, and actually not just the medical care, but also coaching and psychosocial support accessible for all women. And that includes commercially insured populations, ACA, exchange, Medicare, and Medicaid. And we've seen this model really take off successfully. The formatting is a little bit wonky here, but revenue growth and patient visit growth is up double digits. We're seeing really impressive improvement in symptom management. And I think, probably one of the things I'm most proud of is the ability to convey to health plans that this is an opportunity for them to capture value. And we've grown, I think, more health plan contracts in 18 months, so 0 to 46, than, anybody else I know kind of in the peer space, in the virtual space. Next slide, please. I'm going to skip over the symptoms. I think many of us are familiar with them, but just to note that if you look at the number of providers who are certified in menopause care, meaning they've undertaken additional training and sat for an exam, the number is puny, a fraction of 1%. And the analogy I like to use is for those of us that have kids, if only a fraction of pediatricians were comfortable with puberty and adolescence, there would be like riots in the streets. But this is the space that we have the opportunity to turn around. And it's an enormous TAM. There's room for multiple enormous organizations to be built, specifically focusing on women's health in these midlife decades. So patients at Elektra are in their 40s, 50s, 60s, some into their 70s. And the goal is really helping them to improve both their symptoms and quality of life, but also how they age in the
1
decades
minute,
that follow.
Jannine, 1 minute.
Thank you, Lexi. Thank you, Jagruti. Next slide, please. So I was mentioning that part of our unlock has really been around conveying the opportunity to payers. So that's health insurance companies that are seeing women who are symptomatic but not being treated appropriately have higher costs. And that's really been a message that has resonated. Next slide, please. One more. Evidenced by most recent announcement, which was the first ever health plan we co-built with Oscar Health. It's going live in January, and we'll be tripling our footprint to expand access to all of these new patients. So I'm really happy to share this. We'd love any introductions to more health plans, but other than that, I'm just pleased to share the progress, and thank you for your time.
Thank you so much. Can you maybe share a little bit on sort of the benefit that the health plans will get as a result of treating this?
Yeah, I think there's a few things. I mean, one of them from just the perspective of ROI is we've looked at the claims data and we've understood that patients who are symptomatic in this time of life, typically incurring symptoms coded as menopause symptoms, but without a menopause diagnosis and treatment, cost 4 times as much. And so they're very aware that, there's both the menopause cost, which is not as large as, say, the folks that are coming to the emergency room all the time, but it's a huge population. So to be able to save, even $5,000 per member per year, which is about the amount we're talking about, is a significant opportunity for the plan. And these women are also, I think, Shital's presentation speaks to the care gaps. Like it's also the same population that is behind on care gaps. 40% of our members aren't up to date on a mammogram. There's additional incentives for the plans to be able to engage and close gaps for that population. And then lastly, this is just probably many of us on this call are the demographic that is the customer of the plan. Like we are making those decisions. And if they're not doing anything to differentiate and engage, then they're going to fall behind their competition.
Yeah, really good points.
Following on what Jagruti was just mentioning, have you highlighted the top 5 reasons for the, medical issues or greater costs that may be helpful? I see you have here an idea of someone was offered Zoloft, but it's not clear what they were offered Zoloft for, if they were having, depression, trouble with sleep, or other issues. So that may be really helpful when you're presenting this.
Sure. Yeah, I'm happy to detail. I mean, it's always a confluence of symptoms and feeling, unheard or dismissed by traditional providers typically, and looking for additional support. I think for the payers, it's really about gaps in care, Unfortunately, I think they're less concerned with the symptom suffering, but it just depends on the audience.
Yeah, I would say it's a combination because if you can put it together, if you could put the claims data together with the medical reasons for which people are coming in and not getting adequate treatment for, I think you have a nice, a nice combination.
Yeah, no, we definitely have that. It just didn't make it into the first few minutes.
I have a question. Jannine, first of all, this is great. Thank you so much. And it's such an underserved area, that's for sure. And this is an area where because of a life stage problem, I'm getting bombarded by a lot of ads, and there are a lot of players out there. But I think from what I understand, from what you're saying, there could be 10 players, but it's probably still going to remain an underserved for a long, long time. How do I think about Elektra vis-a-vis some of these other players that are very heavily advertising?
Great question. So I think, first of all, Elektra's, and one of the reasons I think we've been successful with both health plans and health systems, I didn't really talk about that, but we get vetted pretty heavily working with Mount Sinai, University of Pittsburgh Medical Center. So the quality of care is really important. And every chief medical officer we are vetted by wants to know, do you prescribe non-FDA approved treatments? Like, for example, some of our peers in the space are compounded medications that are cash pay. And the answer is no, we don't. We only prescribe guideline concordant, FDA approved, evidence-based treatments. And that's important for our patients because we serve the whole spectrum of the population. So that includes Medicaid members who need to be able to use their insurance and their pharmacy benefits to cover their medication. So that's, access, adherence to the gold standard in evidence. And we also don't sell or monetize medications or products and supplements. So our patients trust that we're delivering clinical and non-clinical support, so education and coaching, but we are not monetizing when we recommend that they start hormone therapy, for example.
Thank you.
A quick question. I was wondering if it was a conscious decision to approach health plans versus how did you think about partnering with self-funded employers, for example? Because with a lot of companies, we hear that the sales cycles are faster, easier, etc.
With which one?
With easier with self-funded employers.
I don't think so in my experience. And we did spend a lot of time. We did contract with, and we have some legacy employer contracts. The two problems in that space are one, if they're already, unfortunately, despite what you hear sometimes in the HR world that they care about retaining women in the workforce, I have found that what they care most about is, and understandably so, the costs associated with fertility treatments and maternal health. So the costs that jump off the page that are sucking up the budget are not tied to menopause. And the argument for retention and productivity is certainly there, but it is not enough of an argument to focus on a menopause solution, really on its own merits. However, if you are working with a Maven or a Progeny and they have a check the box, like, sure, we cover menopause, and that's like perfectly fine for most employers. And so that's part of the rationale.
Thank you. Thank you, Jannine. Excellent.
Yeah.
I think we need to move on. We are going to just do a little switcheroo because Farhaneh, who's presenting later, is actually at the gate looking to board a plane. And so, all right, Farhaneh, you're up. And Alexi, I hope the slides work out. Oh, look at that magic. Farhaneh, are you there?
I am, yes. Can you hear me?
Yes.
Perfect. Thank you very much for switching this around. I really appreciate it. And to start us off, at eddii, we provide complete endocrine care, and we are redefining endocrine care by, sorry, if we can go to the next slide. By combining real-time patient data with expert clinical care, leading to personalized care for each and every one of our patients. And we have proven, well, our North Star is both to improve access and outcomes. And so far, we have proven both. Can we go to the next slide, please? So in terms of access, we have partnered with one of the largest payers in the country with over 10 million members for a value-based care model. And we are conducting that pilot as we speak. It is focused on outcomes, cost reduction, and an improved utilization of endocrine services. As we speak, we have 2,100 patients who are receiving clinical care with eddii, and we have 40,000 users who are managing their endocrine condition on our platform every day. Next slide, please. In terms of our outcomes, for our pediatric population, we have proven 5.38% in time and range, which is equivalent to 1.5 additional hours of these kids having optimal glucose control. All of these children lived with type 1 diabetes versus the control group, and we published our outcomes in the Journal of Diabetes Science and Technology. For our adult population, we have proven real-time evidence of 5% improvement in time and range for our entire population. Next slide. And we have strategic partners across the industry. We partner with Dexcom and Abbott, both for real-time API with their continuous glucose monitors. We encourage especially our diabetes metabolic health population to wear continuous glucose monitors. We prescribe it for them, both for monitoring and to improve outcomes. We also partner with nonprofit organizations. And as we speak, we are also partnering with large pharma companies to improve access to a lot of their drugs. Next slide, please. Now, taking a step back and thinking of the problem we're solving here, in this slide is a little reformatted, but overall, over 100 million patients are referred to endocrine care every year, requiring 400 million appointments in the US for specialty endocrine care. But because of the shortage in endocrinology specialty, less than 48 million appointments are held, leading to a $36 billion market opportunity for underserved patients who need specialty care but are not receiving it. Next slide, please. And as a result, these patients wait for months for a specialty appointment. They get delayed diagnosis, their condition worsens, they end up in the ER, whether, for example, in the case of diabetes, whether it's with a DKA, a hypo, or other types of emergency. When they are treated by their primary care, they are misdiagnosed. The primary care is a lot of the time not confident enough to put them on the latest drugs or devices, for example, and they end up being undertreated and misdiagnosed. And for tech-only apps, a lot of the time, technology-only apps lack clinical depth. So they're unable, again, to prescribe the right treatment and lead to a lot of undertreatment along the way. Thank you, Chair. So at eddii, we bridge that gap. Not only do we help the patient with their daily management, so we reward their experience, we connect real time to their devices, we help them with tracking, but on that same interface, they can schedule an appointment with an endocrinologist within 48 hours and receive specialty care. We do everything that a brick and mortar clinic would do. We order labs, they can see their lab tests on our platform. We do prior authorizations and we do referrals to infusion centers, imaging facilities, and any other facilities that they might require. Next slide, please. And to give you an overview of our population, 55% of our patients live in medically underserved areas. 65% have one or two endocrine conditions. 81% of our patients who require a follow-up attend them, and 70% of our patients are female because endocrine conditions impact females more than male counterparts. Next slide, please. So a little bit about us. So our founding team, myself and my co-founder, who's also here, we both have experience with endocrine conditions. I live with type 1 diabetes, which is why the company was founded. But we are a strong team of business, operations, clinical, and tech specialty and team who are working on eddii. Right now, we are raising a $2 million round, and we'll be happy to share more details about the round if interested. Thank you.
Great timing. Thank you. Questions from the audience?
Jagruti, if we are interested, then will you be circulating the details, or do we follow up with Farhaneh?
We're happy to circulate.
Yes.
Oh, okay, thank you.
Sorry. Yeah, I think it would be
We're
best.
happy to share more details.
Yeah, it would be best if you connect directly with Farhaneh. Farhaneh, where are you based?
So the team, my co-founder and I are based in New York, but our pilot will be conducted in Illinois, and we are very focused on rural areas. Texas is another priority state for us. So we're, in a nutshell, we're traveling all the time, as you can see.
Yes, indeed.
I lived in Tulsa, Oklahoma for like over a year or 2 years, so everywhere.
Okay.
And we both met at HBS, so we're both MBA 2018.
Well done.
And we hear from our patients they can't get in to see endocrinologists all the time.
We're happy to collaborate if you would like to refer them.
Well,
absolutely.
We'll follow up.
Sounds great. Looking forward.
Do you have a set of clinicians that work for eddii Health?
Yes. So we, our endocrinologists, our head of pediatric endocrinology and adult endocrinology are on the slide already, and we have a team of endocrinologists who work for us for both ped and adult. We are licensed in 38 states for pediatric and 10 states for adults.
We have MDs, NPs, dietitians, diabetes educators, and device experts.
What is your greatest challenge?
Right now, waiting for Medicare, Medicaid to get back to us so that we can expand our coverage. It's been such a long wait. And it's the time, the infrastructure in the healthcare ecosystem that just takes a few months every time we apply for a payer, for coverage, and to be in network. We want to be in network, and we want to ultimately sign as many value-based care contracts as we can. Like, we are grounded in value-based care. So we're aiming for that, but in our ecosystem, everything takes a little longer.
Seems to be a theme, and seems to be healthcare in any case. Any other questions for Farhaneh? Okay, thank you so much.
Thank you for having me.
Yeah, no, thanks for doing a great job from the gate or wherever you are. All right.
Thank you. Bye-bye.
Toni Riley is next.
Thank you. Thank you. Hi, I'm Toni Riley. I'm CEO and founder of Get Well Pals, MBA 99. And I think I am moving this forward. Okay. The problem that we are solving, we are a pediatric concierge service. We provide chaperone and transportation services for children to their medical appointments, as well as sick child care that will be coming soon. And we look at the current problem, we feel like it's a silent crisis to pediatric care with missed appointments, up to 14 million in the US, and those 5 million parents that stay home with sick children, creating up to that 5 billion in lost revenue for the economy from both healthcare industry as well as US employers. And this problem is probably about 10 times that amount on a global basis. Okay. And this is our integrated solution of supervised medical appointments with transportation, allowing parents to video conference in, as well as providing a safe place for them when they're sick, for their children. And we are leveraging AI to make that process of taking a child out of school as seamless as possible. And the way that we're doing that is communicating scheduling and doctors and school notes across medical and school platforms, eliminating about 6 manual steps for parents. And also, we are providing a full suite of concierge services that's differentiating ourselves across all aspects of the visit. And our competitive landscape, if you can see here, shows how we are positioned well with center-based sick child care that supports contagious as well as non-contagious children, as well as the chaperone and transportation services. That is complementing existing offerings of backup child care. And our business model spans across all socioeconomic classes of families with our foundation, supporting low-income families and those with special needs, as well as Medicaid, providing partial funding for transport. And for other income levels, we have monthly subscriptions as well as employers to add as a retention benefit through subsidies for discounts and free visits as well. Our value proposition for chaperone transportation services is as well, and I'll also speak about for sick childcare, but we've quantified the benefit to reduce the cost of temporary PRN staff to be between 1 to 2 million, as well as double-digit millions for missed revenues on a base of, say, 10,000 hospital employees. In our current customer traction, we've been operating for about 8 months now, and started back in 2023, but we've done just over 500 trips, generating about 21,000 in revenue. We currently have a repeat customer base of about 7 families with financial services, healthcare, educational, and gas parents, as well as legal field parents too. And about 120 in our pipeline that have shown interest in these services. Additionally, on the trips, what we look like what that looks like for our children we're serving, we're doing about 60% going for autism therapy, 7% for speech, and just over 30% at hearing loss schools, and 5 schools with primary and elementary, as well as 3 healthcare system partners. This is our foundation that has provided partial funding for chaperone services, about 210 trips since April. And we've also been added to Walmart Spark Good Roundup, an online checkout program, by just simply adding us to your profile. And we'll drop that in the chat if anyone has any interest in doing that with your online holiday shopping.
Toni, you got a minute.
Sure. Active opportunities for B2B, it includes corporate discussions with healthcare, petrochemicals, professional services that are seeking to improve retention for employees. And we have 2 sickle cell foundations that are seeking our services for pediatric patients. In terms of B2C, we'll be diving into our pipeline of customers, as well as multiple collaborations that we have in place. We have also started servicing the elderly community for similar services as well. The ask is around corporate clients that want to improve employee retention, for partners where we can complement their existing services, either through backup childcare providers, healthcare systems, or online care coordination. We can provide a brochure on that information. We're in need of benefactors to continue to support the families we have and to grow that level of support with low-income families, as well as those with children with special needs. And please add us to your Walmart online profiles, and also follow us on social media. Finally, we're seeking an investor funding for our pilot proof of concept around sick child care, as well as our app.
Thank
you. I may be at 1 minute.
Yeah. Well,
okay.
Thank you. Any questions for Toni?
So this is Mary.
Hi, Mary.
Hi. Just curious. So are you a nonprofit? Is that clear?
We're a for-profit and a nonprofit. So the nonprofit foundation is specifically focused on families that cannot afford pediatric concierge
okay.
services. Yeah.
Okay, good,
So
good.
we fund the services for low-income families as well as children with special needs.
Good for you. Excellent.
Thank you.
Great.
And can I ask, I'm sorry, I had to, my computer went down for a moment. Is your focus, I see your focus is Texas now and cities. I would think with this, you would have to have a very scaled rollout
Oh,
from city to
absolutely.
city. Yeah.
Yes,
And
we
that's the
do. We're doing
plan.
our pilot here in Texas in proof of concept. We've done the proof of concept and product market fit on chaperone transportation, but on sick childcare, that's what we're looking at here. We're about to try to work on setting up a sick childcare center in underserved communities as well as for the medical community too in healthcare. So it is one of our projects that we're doing now.
Okay, great.
you.
And your for construction costs and things like that are for the sick child care
Sick child care,
facilities?
that's correct. Correct.
Okay.
Correct. Yes.
Thank you. I think
Well,
we're going to need to move on. So Renee Fry with Gentreo. Renee, are you there?
Okay, you can hear me?
I can.
Yeah. Okay. And then how do I do the buttons? I'm not getting. Oh, okay. I got it. Okay. Well, so Gentreo for us means 3 generations. And we talk about where we started with estate planning, but one of the big documents in estate planning is something called a healthcare proxy. How many of you go to the doctors and every single visit they hand you this piece of paper that says, hey, here's your healthcare proxy. Tell us who you want to make your care decisions, right? Like every time I go and I see my doctor, I'm like, I saw you 2 days ago. And she's like, oh, yes, you did. And I'm like, I still have the same healthcare proxy. But one of the problems is that people can't find the healthcare proxies. They can't find the medication. And so there's a lot of things in the healthcare world that exist, but they don't get used. And so there's many studies, but if you have a healthcare proxy, that can save up to $150,000 in costs just alone in care that wasn't wanted or that you didn't approve. So for Gentreo, we call ourselves the Life Milestone Company. And so no one ever wakes up saying, hey, you know what, today I'm going to get a healthcare proxy. You know, I'm going to go ahead and do a will, things like that. Something has to happen in someone's life. And so in regards to the healthcare world, a lot of us are caring for our aging parents. Like my dad had Alzheimer's, and each time we went to the doctors, it was something that was always, you know, we felt like we were repeating so many processes again and again. Healthcare scares. And so this is where we started thinking about, a lot of people don't wake up thinking, I need a healthcare proxy, I need something like that. They just know the situation, or what we call the life milestone of what they're going through. So today, 70% of Americans don't have a healthcare proxy. They don't know their medication list. Their caregivers don't have those on hand. Many are like my mom, who carried around our dad's medication. He had 14 different medications and about 8 different doctors, maybe it was 12, many more, on a Post-it note. And so she was always in tears, crying, things were happening. And so when we put Gentreo together, we put together things so that you can just hit a button now and you can get your healthcare proxy, the medication list. You can have all that information on what doctor cares for what, who, what, when, so that when you're going through really hard situations, you have that phone app, or not an app, but you have that responsive design Gentreo link that you get to all that information. And so some of the things that we're really excited about is that, you know, from being able to get information to people faster and making sure that when you have things like your healthcare proxy and things like that, people know your wishes. And from an insurance standpoint, this saves tons of money along the way. It's not something that's wildly popular because people don't want to say, yes, we'd like to, you know, end your life sooner, but it is something that the patients want. And so you really have to be there to help them execute the decisions they want. So we do a lot around state-specific legal documents like wills, healthcare proxies, other things like powers of attorney, and we also just introduced some Medicare calculators and things like that. We do a lot also in other life milestones around how do you think about what happens when you care for those aging parents. When you're traveling, you need your medication list. If we're traveling over to Fiji and Australia, and I have 3 different medications, but I need to make sure there's a way someone, because I'll never lose my phone. I might lose my child, hopefully not, but I won't lose my phone. So that's about having information that you need to be there. And so from the healthcare documents that matter, and these are some of the things here, but your living will, the healthcare proxy, your emergency documents, it's all about helping people create those documents, but then save and share them, and then having things like our emergency access buttons and things like that, so that when things do happen, you can be there for people. Yep, and then so on the LifeSafe, that's our digital vault. We're doing some really cool things with AI, helping people understand what are some of the things they might also be missing. And then from the funeral insurance and healthcare continuum, we've also added a few benefits around those things, because some of the things that people, once emergencies did happen, they didn't know what to do. So we've been trying to help people get the right information and not get taken advantage of. So we have lots of partners. Typically, we partner with a lot of credit unions and banks, but we are trying to do more in the healthcare space. So we're looking for help with that. And we're also looking toward helping really with our legacy registry and letting people understand what people have as wishes. We're raising our next round, and so we have fantastic partners. Today we're in over 120 credit unions and banks. We partner with many different companies and employee providers, and so we're raising our next round in order to grow. And I appreciate the opportunity today and look forward to any questions.
Thank you. Questions?
So this is being marketed to consumers?
We actually go B2B. So we work with a number of, this is where, so it's B2B to C. So we work with a number of banks, credit unions, employers, and they put it out now as like their new life milestone approach. And so like the Harvard Credit Union is one of our best customers, the MIT Credit Unions. And what they're trying to do is, instead of people understanding what type of things they need, they're trying to say, hey, are you caring for that aging parent? Let's get you Gentreo. Let's get you those healthcare proxies. Let's get you that vault. Let's help you understand that we know what you're going through.
So they're offering it as a customer retention type of tool.
That's exactly what it is. Yeah, yeah. And so, and we have a 93% retention rate over 3 years. So once we get folks, we keep them because they have all that information there, and they know that they can share it with their families. And when things happen, it's all there for them.
Great. Yes, it is important.
Yeah. So if you don't have all those good things set up, gentreo.com. It's a good place because we're lots of fun at the reunions and things, but it is amazing how no one's tackled these things. Or they're like, oh yeah, I had a healthcare proxy. Oh yeah, we're like, or even if your kid's 18, they're an adult now, and you need these documents, and they're like, oh, I have no idea where that healthcare proxy is. And we're like, okay, your kid is now an adult, and when they're at college, you're not going to be able to call up and say, I want their medical records. And so what we found is that putting these documents in place for families makes a huge difference, because when they're looking at healthcare concerns and decisions, it makes life so much easier if you know what people want.
I just had a friend whose father had a healthcare proxy. They couldn't find it, got treatment that was not needed, exactly to your point. So thank you for sharing. Yeah.
Thank you.
Luckily they did find it in time. Thank you for sharing, Renee. And we're going to move on to Mary.
I'm trying, and I lost the whole presentation is gone. I hear you all. Bear with me. I tried clicking on something. That was my fatal mistake.
We do see your slides on the screen.
Oh, okay. I
don't
bet you
mind doing
that's,
it for you.
I bet that, well, this might be me. Can you see my pointer? No?
Oh, maybe. Try again. Yeah, we did see, I saw the arrow move.
I'm going back and forth. I don't know what I'm in because I would have zoomed and there it is. Bear with me. Let's see if I can get back in. What did I do? And why aren't you big? Here we go. There. Oh, thank God. It is
Let's
so
go.
me. So do I click on the word share to do this?
Just click anywhere and it'll go.
Okay.
Move on.
All right. Sorry. Okay. So I'm Mary Weitzel. Yes, I've known Jagruti since 1984. And I am CEO and co-founder of Yaso Therapeutics. I also serve as the principal investigator on all our R&D work that is funded by the National Institutes of Health. And we're pioneering the next generation of non-hormonal contraceptives and breakthrough antimicrobials to combat the urgent global health threats that are around us. Okay, I'm trying. There we go. Oh, shoot, I went too far. Back, back, back. There we go. There, I'm getting it. Okay. So the biggest health crisis that I'm going to touch on today is inadequate offerings of contraceptives and the drug-resistant strains of gonorrhea. In the United States, 16 million women who wish to avoid pregnancy use low efficacy or no contraceptives at all. And globally, you will find that 224 million women are in the same predicament. So there's a critical need for safer and accessible contraceptives worldwide, and we're trying to address that problem. On top of it, our drug works against gonorrhea, which happens to be in the 5 global health threats, top threats by the CDC and WHO. And it's because there's resistant strains to all current antibiotics, and all those strains are found worldwide. Here's our answer. It's a cool little drug we call polyphenylene carboxymethylene. We call it PPCM. And it's a multi-purpose molecule. It's a small molecule and it renders sperm infertile and it inhibits infections, a variety of those. And what's great about this, I'm an old manufacturing person. I love the fact that this drug is water soluble. It has a very simple synthesis and the raw materials are low cost. So we have a lot there to help keep the cost down. Thus far, it appears to be safe. It's non-mutagenic, non-irritating, and it's non-inflammatory. Here's a quick snapshot of our gel that we're testing right now. It's vaginally applied as a contraceptive. And just to emphasize, the drug works against sperm, it works against a variety of viruses, and it certainly works against gonorrhea. So just a quick bit of data. In a rabbit contraceptive study, the gel was 100% contraceptive, prevented all pregnancy. So we feel we have a high likelihood of clinical success. This busy little slide is about gonorrhea. And what's on the left-hand column are a list of drug-resistant strains, which are resistant to the most current drugs that they use today to treat gonorrhea. And what we see is that the drug is still highly effective. It works against every strain it's tested against. And the gonorrhea folks that are interested in working on this are very excited, really hope we get something to market. Right now, we're starting our clinical trial, and this is our first in human clinical trial. It's a big milestone for us to get there. We've taken the drug from benchtop to our clinical trial. This trial is being conducted at the University of Pittsburgh Magee Women's Research Institute, and it's one of the best in the United States for these kinds of contraceptive studies. The trial is being led by Dr. Beatrice Chen, who is super rigorous, let me tell you, but excellent hands. On our end, we have Philippa Kwai, who has almost 20 years of experience running clinical trials, and she's the one who coordinates everything, whatever goes on at UPitt and all the other labs that we are sending samples to. Just want to point out, this is my co-founder, one of my co-founders, Barbara North. She's our chief medical officer, and she's been in the contraceptive world since the early 80s. I want to point out the 3 incredible
1 minute,
professors. Mary. Okay, I'll go quick. These 3 are working on sperm, gonorrhea, and HIV. Okay, PPCM, it works as designed. It could prevent disease, treat disease, and it's contraceptive, low cost, and we're going to sell it over the counter so we have high access. There's nothing else like it on the market today. Here's our status. We've been awarded in total a little over $10 million by NIH to develop this drug and these applications. We're starting our clinical trial, And in the winter, I need to start raising the $7 million seed round so we can fund further development. You see the writing, manufacturing cost is key, and also developing other applications to sell, out-license or sell for acquisition. And partnerships will be critical to our success. So that's my fast description of what we've been working on and where we're at today.
Great, thank you. Questions?
Kudos, I absolutely love it. Sorry, I don't see hands up, but I
I don't
absolutely
have
love
them
this.
either.
Yeah. So a quick question, because initially with your first title, I'm like, why mix contraceptives with antibiotics or antimicrobials? But then the second slide, I got it. You may want to kind of address that on the first slide because I think it is genius to offer all that. The other part, and that's the $1 million question about the viruses that you could address. Would that include herpes or HPV, HIV? I mean, those are the ones that most people worry about. So I would just call it, because it's like that is absolutely huge.
Trying to do HIV studies, you're probably familiar with all of those. They're huge and hugely expensive.
Yeah.
So I don't know if that'll ever become a reality, but we are testing samples from women who are being dosed with the drug product during this study. And Irvy at University of Pittsburgh will be evaluating it still in an in vitro setting to see if it's still working against HIV. We're just continue to push it. It works. It's excellent. In fact, it's most effective against HIV over anything else, but it's very active against herpes, does a great job. It actually, Ebola is one that's actually sexually transmitted, and it works really well against Ebola. So we feel really great about that. And then gonorrhea is interesting because it's water soluble. We can work on a number of applications, one of which we're talking about an oral application at this time, for instance. That's where they think all the drug-resistant strains are being generated. So it's just, the sky's the limit, and I need Oprah Winfrey's money to do all this.
And you can prevent blindness in children, who are born if their parents. And there's so many countries where HIV is endemic or many of these other conditions. So this is like a worldwide
absolutely
opportunity. Fantastic. Nicely
it's
done.
so exciting, and it's a real personal. I think Job Rudy was. Man, I don't know. You missed that phone call. It's a real personal mission thing for me, with a lot of background stories. Is just like to be presented with this opportunity. My work experience feeds it. It's like, why would I not do this? It's exciting. Everybody on my team's excited.
Thank you, Mary. Guys, we're going to be a little bit over time, and I want to make sure we're both respectful of your time, but also of the presenters. So I hope you can all stay for, maybe 5 or 10 minutes over. So let's move to Kirsten, Hund, Blair, who's going to talk about Lambent data. And then we're going to close it off with the superstar Laura Yecies. So please stay for that.
So Jagrudi, I don't know if you saw my note. I can't stay. I'm supposed to give a presentation to a clinician.
Oh,
At
geez.
2:30.
I mean, Laura, do you want to go now?
If you don't mind, if that be
Yeah, that's
possible,
fine.
I'll go fast.
That's fine.
Okay, let's go with Laura then. Thank you, Alexi, for accommodating the slides.
So while you put them up, I'm the CEO of Osteoboost Health, and we are the first and only non-drug prescription treatment for low bone density, osteopenia and osteoporosis. And we won a bunch of Harvard Business School competitions and Dartmouth and others. And then actually there's an HBS case that Regina Hertzlinger just taught. So lots of fun HBS connections. And, this is something that affects, I don't know how many people are in this call, 30, half of us will fracture. And more women will actually die of hip fractures than breast cancer. So this is a common problem and a serious problem. Next. And actually, the problem starts in menopause with osteopenia. And what a lot of people don't realize is that osteoporosis has higher fracture risk, but osteopenia has the majority of the fractures. And so clearly we need an early intervention. Next. And until Osteoboost, there were actually no FDA-cleared prescription treatments for osteopenia. The treatments have been the drugs for osteoporosis, and less than 6% of patients with osteoporosis are actually using pharmacotherapy. And this is because of the serious side effects, an example of which is shown in this New York Times article, an atypical femur fracture. And on the other hand, the supplements and the typical exercise most women do is not enough. Next. And so we have developed leveraging research by NASA on vibration, which was studied for astronauts who lose bone density. We applied vibration to the hips and lumbar spine, the vulnerable anatomy, and we showed that we reduced the loss of bone by over 85%. It's a 30-minute-a-day treatment. And as a wearable, it's very convenient to use. We received a de novo approval. And so, yeah, first of its kind for osteopenia, non-drug for low bone density. Next. This is an illustration of our clinical benefit. It was a gold standard randomized controlled trial. This formed the basis of our FDA approval. Next. And we also are building a comprehensive solution. So we acquired Wellen, an osteoporosis-specific exercise program, and we're building out clinical services, nutrition, really everything that people need. And no one is really providing a comprehensive solution for bone health. Next. This is an enormous market with so many patients. This is as big as kind of high cholesterol, high blood pressure. And it's also kind of a hot topic with all of the focus on menopause. And, based on this, next, I think we're seeing just a lot of inbound interest. We have sold over $2.7 million worth of products since we launched. We launched in May. We're seeing very high gross margins. We received a Time Innovation of the Year award, a lot of great coverage, and also very attractive customer acquisition costs. And I think this is really driven by the demand and unmet need. It is a prescription treatment. We need to partner with clinicians. We have over 2,300 doctors actively prescribing, many repeat prescribers, and we're seeing really the leading health systems and looking to partner with menopause focused companies. Next. We are working on remote therapeutic monitoring, standing up that, which are existing codes that we can use for Medicare and commercial reimbursement. So part of our current goals for next year is to put this in place. Next. Our goal is to really get to a $40 million run rate. In order to do that, based on our existing metrics, we need a little bit over 2,000 repeat prescribers. So we're on our way, but a lot to do this next year. But we're getting to them through both the patients and the specialty physicians. Next. So we've been raising a safe round, and Harvard Business School angels and some other accredited investor groups have come in. We decided to launch a WeFunder campaign to open this up. We've had a lot of patients who have been interested in partnering. So it's an exciting time as we grow the business. And I've really appreciated the collaboration from other HBS women and HBS angels and the alumni group. It's really been a big part of our journey. And I'll stop there.
Thank you. A big market for sure. How long does the device last, Laura?
Yeah, it should last at least 3 years. That's sort of a DME requirement. Our goal, of course, is it lasts longer than that. One of the things that we want to do this next year is to provide a hardware subscription. So the way people get it now is they purchase it. It's $1,000 from our website. But we want to offer kind of a monthly version where it would sort of be like the iPhone. You pay per month, and every 2 years you would get, a fresh version. So
great idea. Questions?
And does it work also? You said it's to address the osteopenia market, and some people have taken like the Fosamax, end up going back into osteopenia from
Yeah,
osteoporosis. So how does that work in terms of people who may have
yeah.
either done
So
treatment or not had any?
our indication for use is postmenopausal women with osteopenia. Prior use of Fosamax is not a contraindication. In fact, I think it's a really good use, a good fit for that drug holiday period. I'll also say that more than half of our patients, we see this from the prescriptions, already have osteoporosis. It's not contraindicated, it's just not what we studied. But due to sort of the need for more effect size, I think some patients are using it with pharma or instead of or during the holiday. Not everyone gets back to osteopenia from Fosamax. There's no downside, right? The device is very safe. And by the way,
But
we're
one thing
doing
is,
a webinar tomorrow with the chief of Stanford Endocrinology who led the Fosamax trial. So that's tomorrow. I just posted about that on LinkedIn, and I'll put a link in the chat if anyone, it's clinical, for anyone who's interested.
Great.
thank you. Well, by the way, there's also delays in bone density tests. You have to wait almost a year, even in places like Boston through MGH, which just boggles my mind. But
That's amazing.
And,
Yeah.
and Laura, do you advocate for any specific nutrition or diet?
I mean, adequate calcium, adequate protein, get your vitamin D levels checked. That's like the basics. Get your parathyroid hormone level checked, especially, if you're losing bone, if your Z score is low.
So
Some
it's not
people do
plant-based.
vitamin K. I'm sorry?
It's not plant-based, avoiding
We don't have a recommendation one
a
way or the
specific.
other. You need the calcium and you need the protein. A lot of plant-based folks are light on protein. But
What would
it's
be
not,
plant-based
it's
protein?
possible. Yeah, it's all possible.
I was just curious. Thank you.
All right, thank you. I think we'll leave it there. Laura, thank you so much.
Thanks so much.
And Kirsten, thank you for accommodating the switcheroo. And we are
course.
here
And
ready to
actually,
listen to you.
congratulations, Laura, as my section mate when we started in 88 in H, and then I graduated with 89 because I also did an MPA at the Kennedy School. So congratulations to all the other entrepreneurs. So I will try to advance these. It doesn't seem like it's moving. And I'm wondering, let's see. I'm wondering whether it would be okay, Alexi, if I just shared my own screen since I'm the last. I could share it from my actual computer.
Yep, you
Would
can do that.
Would that be okay? Let's try it. Let's try that. Let's see. Can you all see that? And then I'll get into the slideshow mode.
Yes.
Okay. Thank you so much. I'll just dive right in. People in reentry and recovery are facing major challenges in their transitions that affect them and their family members. So this is health, housing, jobs, education, transportation, childcare, and even food insecurity. And these are also as they're seeking to build their careers. So you can see the challenges in unemployment for people with reentry from prison or jail, and also in recovery. This leads to a lot of recidivism and relapse. There are a lot of multiple factors in terms of why people are rearrested or are reincarcerated, or on the side of recovery, why people relapse. But the fact that they're facing a lot of different challenges and social drivers of health, and then also other factors cause this prevalent and costly issue. So there's large funding opportunities in this space because both on the reentry and the recovery. There's financial incentives for the groups that are paying for jails to put money into reentry. And then similarly with recovery, self-insured companies and payers have a strong financial interest to reduce relapse. There's also the opioid settlement funds, which are from companies. Now, the issue that we're tackling is that the technology in this space is not robustly engaging the clients and patients. And so there is technology in the pre-release stage, like different education and job skill platforms, but it doesn't really follow through. And then in the reentry and recovery phase, a lot of organizations are working with paper and pen or PDFs of case plans. Or the case management is really geared on the case manager side. Even referral platforms are maybe mainly geared on the case management. And then there are different consumer apps, but those are not connected very well to the providers. And so what we've done is built Outreach. It's a highly customizable collaborative SaaS platform and app. And our customers are the organizations in healthcare and social services, and they provide the logins to their staff and mentors, as well as to people in reentry and recovery. It's equipping both sides of the trusted relationship, and it's research-based. So this in the middle is Recovery Capital. This is a best practice in both recovery and reentry, where you're building up this capital to help you thrive. And so the green arrows are showing what we've done in Outreach software in each of these arenas. So we have milestones and healthy habits. We have a collaborative approach because staff and mentors are critical. And then also the social drivers of health. So we have a lot of traction in terms of our customers. They're currently not-for-profit organizations. We have some channel partners and then a strong active pipeline. I want to focus on our near-term scaling. We're in very detailed conversations with a behavioral health provider where the CEO is very excited about our outreach because of the feedback he's been getting from payers to improve the engagement and outcomes, et cetera. We have some other near-term scaling opportunities as well.
Kirsten.
Okay. Yeah. So very quickly, I'll just zip through this to show you what this is and then show you a business stuff. So we have Mallory, who's reentering the community from both reentry and recovery, and then her caseworker, who's also stressed. So Outreach app can be used on any device. There's personalized milestones with micro goals. She can look at the goals in progress, all of this between her visits with the caseworker, add it to her calendar. She can look at each milestone by itself. And then there's all these links to trusted resources, both evergreen resources as well as searchable local resources. And then the practitioners can build customized elements to complement their specific programs. Lots of communication, and then a lot of data analytics, which is much more granular than what is currently available. So in both cases, they're thriving, both the participant and the case manager. We've gotten excellent ratings from the users. And then the business side, quickly, this is a bottom-up calculation of revenue based on what the number of organizations in these different fields and the revenue per organization that they would pay to Lambent. I talked about the self-insured companies and other payers. We have detailed charts that we were discussing with the CEO. Our revenue is, early stage, but we anticipate a strong uptick. And then we have a great leadership team and advisors, both, in the content areas as well as in finance and software. And then We welcome further introductions to potential customers as well as additional investment.
Thank you.
So yes, and this is our last
slide.
Thank
you, Kirsten. That's great. Questions? How do you scale, Kirsten?
Yeah, so the scaling is through the different organizations. I'll show this slide that are right now. We've been proving this out with the smaller not-for-profit organizations, but this slide really talks about the scaling. So this behavioral health provider that we're in active discussions with the 2,500 patients, that would be our first kind of medical setting, and we are able to connect into their electronic health record system. We have some other systems of behavioral health, a national organization. So we have a very specific list of active scaling opportunities where we're having conversations with the leadership, both also in reentry.
You're starting with recovery because that's probably a bigger market, I would guess.
Well, our traction actually kind of spans both because, in fact, there's indeed an overlap in these areas. And so currently our customers span both the reentry and recovery space.
Great.
But I agree with you that financially the recovery space in the behavioral health providers would, potentially create a quicker opportunity for scaling. But again, as everybody's talked about, there's, there can be long sales cycles. And so that's where we're also have developed these relationships in the reentry field. We're part of the Mercer County Reentry Coalition, which is in our local New Jersey area. And so we're kind of pursuing various tracks at this point.
Well, thank you, Kirsten.
Thank you.
Thank all the presenters. I think this was an amazing startup showcase, and we'll certainly have more, I think, as this talented group that we have has more startups. So thank you very much for joining. We will continue our Women in Healthcare series starting in January. The January one will be, what is it? Ask and Give. It's more of a networking event. And then we have, for February, hopefully we have Michael Greeley of Flair Capital talking about venture capital in healthcare. So we have a lot of interesting speakers lined up as well. So thank you so much for joining. And happy holidays.
Thank you, Chakriti, for setting this up. Happy holidays.
Have a great one. Great seeing everyone.
Thank you, everyone.
Thank you.